2017, 2025, focal onset seizure is now being called a focal seizure. Generalized onset seizure is a generalized seizure. Awareness as a classifier is now being called consciousness, which is defined as awareness plus responsiveness. Then motor versus non-motor is observable versus without observable manifestation. And then I've already talked about the number that has moved from 63 to 21. And then first symptom used to be emphasized a lot, but now in the 2025 classification is chronology being emphasized. So this matters to psychiatrists among other cadres, that clearer terminology improves communication with other colleagues, neurologists and the like. Emphasis on observable manifestations aligns with psychiatric history taking, and then recognition that conscious impairment can be partial, important when distinguishing epileptic from psychiatric events. Okay, so I've highlighted this. So focal aware changes in focal aware seizure became focal preserved consciousness seizure. And then focal impaired awareness becomes focal impaired consciousness seizure. Unknown onset seizure became unknown, whether focal or generalized. It brings some more clarity. And the other thing that has been emphasized now is the definition of consciousness and how to deal with this in our day-to-day clinic settings. During a seizure, how to assess consciousness during a seizure is now defined by two components. One, awareness, which is recall. So you ask the patient, could you remember what happened during the event? And this brings up very interesting answers. So yes, no. Responsiveness, could you respond to others during the event? Okay, is another question you can ask. So how do you go from here? If both awareness and responsiveness are intact, that is preserved consciousness. If either awareness or responsiveness is impaired, you will call it impaired consciousness. I hope that is very clear. If the patient had ictoaphasia, okay, but could respond to nonverbal cues, consider that as preserved consciousness. Some forms of epilepsy, the patient it gets mute and it's related to the seizure, but they can't talk. But they can respond to you rather, okay? So if patient has ictoamnesia, but was responsive, consider as preserved consciousness. So the clinical implications and special considerations here, children who are less than 4 or 5 years, awareness may be difficult may not be as accessible. So you might rely only on responsiveness. And then ictoaphasia. So unresponsiveness may not indicate impaired consciousness. That's very important to note. Ectoparesis, motor impairment may not indicate impaired consciousness. Post-ictoamnesia, not icto, does not alter classification. I hope that makes sense. So if the thing to save in our memory is that if the state of consciousness is unknown, classify under the parent term, focal seizure or seizure of unknown origin. When taking history, ask specifically, could you remember what happened? And then I've already highlighted that. So there's still other important things that I'd want to share more on with the classification, but the gist of the study goes beyond this. So I'd like to skip this part of the presentation that breaks down the different types of seizure classifications. On to something else, key syndromes, perhaps every psychiatrist should know. Childhood absence epilepsy, typical 3-Hz spike features on the EEG, and this is the classical age. And the child has very many seizures per day, and usually comorbid with ADHD, learning difficulties, depression, and anxiety. JME, juvenile myoclonic epilepsy, usually that's the age range 10 to 24, and with myoclonic Jackson awakening and photosensitivity. Depression, anxiety, impulsivity, social isolation are common psychiatric comorbidities. Dravet happens within the first year. Prolonged febrile seizures, and genetically there's the SCNA1, 1A mutation. Typically shows up with ADHD, autism, and other behavioral disturbances. Lennox usually shows up in children less than 8 years, multiple seizure type presentations, and slow spike wave on the EEG. Intellectual disability and behavioral problems are common psychiatric presentation. Idiopathic generalized adolescent epilepsy, adolescent adults, GTC, myoclonic, usual executive functioning gets impaired, impulsivity, attention problems are also seen. So when differentiating these seizure types, age of onset, usually childhood for generalized epilepsies, focal epilepsies usually at any age. Auras are not common in generalized epilepsies, while they're common and location specific. So, e.g., sensory or epigastric. Ictal events, so absence, myoclonic, tonic-clonic are the ictal events in generalized epilepsies, while focal epilepsies usually have focal awareness or impaired awareness of focal bilateral, tonic-clonic ictal events. The post-ictal events commonly after generalized tonic-clonic seizures, not after absence and myoclonic. That's for the generalized epilepsies, and then common after all except focal aware. Many of the generalized epilepsies have positive family history of epilepsy, and they're rarely positive in the focal, except in familial cases. Risk factors may be absent in generalized, while there is maybe a risk factor like trauma, infection, or stroke in the focal epilepsies. The EEG features a generalized spike wave, while focal epileptiform discharges in the EEG for the focal epilepsies. Most MRIs are normal in generalized epilepsies and are not necessary for diagnosis. If an MRI is done for focal epilepsies, you'll see some structural abnormalities. So where does that take us? The interface between psychiatry and epilepsy. We've talked about these comorbidities. We hadn't touched on the psychosis, interictal, between the seizures. 7% have a 6 to 12 times more frequent, more likelihood of getting psychosis than the general population. I hope this makes sense why psychiatry can't run away from epilepsy and vice versa. The psychosis rates are this high compared to the general population. The depression rates are this high. Cognitive impairment is variable, but up to 50% for those who get chronic epilepsy. Personality disorders are increased, especially intellectual dysphoria, ADHD, elevated in pediatric epilepsies, and suicidality is more than 5% in some cases, five times higher. So some of the psychiatric symptoms related to the seizures itself, not functional. So pre-ictal, hours of days, we used to call this the prodrome, this pre-ictal thing, hours of days before the seizure, the patient may feel a certain combination of symptoms, which may range from irritability, dysphoria, anxiety, insomnia. Some feel sick, some even get nauseated, some may get headaches. And this happens before, way before. It can even be a whole week before the seizure event happens. And then the seizure itself, sometimes they feel fear. And when there's fear, ectophear, you know that the amygdala is involved. So thoughts of a temporal lobe involvement is higher. Again, laughter, galactic seizures can be one of the presentation. Then we think of a hypothalamic hamartoma, or again, all these things are within the temporal lobe area. Crying, dyscrastic seizures, typically associated with the temporal lobe or frontal lobe. Then ectopanic may mimic a panic disorder perfectly. The after seizures or postictal, confusion, agitation, depression, psychosis, suicidal ideation are typical. Then the postictal psychosis is a psychiatric emergence, just to pull it out of the rest. It occurs in 2% of epilepsy patients and rises after lucid interval, 4 to 48 hours. Hallucinations, delusions, religious, persecutory aggression is very, very common. Very common in postictal psychosis and in epilepsy, in most patients who get these epilepsy attacks. Do not, the critical thing is that it does not respond to antipsychotics alone. Treating underlying seizure activity is essential. What this really says, if you have misdiagnosed and you just see the psychosis and you do not manage the seizures appropriately or optimize the AEDs, you get in trouble. So let me try to fly. These things are going to be shared with you. Key is 20 to 30% psychogenic non-epileptic spells, or we could call it let me put it down to the features. It would be a conversion disorder presenting as seizures. That's what PNS is. And in your clinic, look out for the following: pre-ictal headache, eye closure, during the seizure, waxing and waning motor activity. The waxing and waning motor activity is basically there seems to be a rhythm to this thingy, and it's slow breathing, sometimes side to side head movements. Yes,
I think that we
please.
have about 5 minutes left, so
Oh, good.
so
Okay. So this is CBT is the mainstay for that. Let me get to the juice of this presentation in these 5 minutes. These things we're going to see, we're going to deal with. Why is it a big deal? The case for early detection. Why should we bother to diagnose early? These are some of the studies that I tried to check to break down. How long does it take for epilepsy to get diagnosed? In Finland, they diagnose at 12 months. Specifically, they even broke this down to focal kinds. 7 months in some cases, there's a delay. For them, they're counting it in months. In Uganda, Dr. Kadumukasa and Dr. Nakasuja and Professor Masese did a study and found that the average delay to diagnosis ranged between 2 to 5 years in Uganda. So ours is way worse. By the time you get to see the person, they've been convulsing for so long. And so more than 77% of the patients had 2 seizures before diagnosis. 45 had 3 to 10 seizures before treatment. Okay, 15% had diagnostic delays greater than 10 years. So this is how serious this is. Okay. So the key thing that these studies show is that at the time many patients are evaluated, they've been having recurrent undiagnosed seizures. And these have significant consequences. Why the delay is important, or why most diagnoses are delayed, is because if the seizure is not your generalized tonic clonic, it will be missed on average. If there are some behavioral manifestations, semi-automatic activities, most time people will not think of it as epilepsy, so it will be missed. Okay? So, jamais vu, déjà vu, depersonalization, fear presentations, all those will ultimately get missed. So the consequences of delayed recognition result in delayed treatment and seizure progression, injuries, motor vehicle accidents, progression to SUDEP. SUDEP is sudden death in epilepsy. We see that fairly often in Butabika. It's one of those interesting things. There's a hidden cost to these preventable injuries. USA has studied and found that 5% of people who get into motor vehicle accidents have epilepsy. They've either been driving or get knocked in some form. And then this is 1,816 motor vehicle accidents due to undiagnosed non-motor seizures. There's an economic cost to this, but the key thing I want us to think of in this is something physiological, that the effect of convulsing on the nerve centers is such as to render the occurrence of another more easy to intensify the predisposition that already exists. Thus, every fit may be said to be, in part, the result of those that have preceded it and the cause of those that will follow it. And so the observation is people will have one seizure today and have another one at the end of the year, and those will be 2 seizures in a year. But in the subsequent year, they'll have 4 seizures. In the subsequent year, they may have up to 50 seizures. Okay, one seizure generates another seizure. Okay, cognitive development. You're going to find these studies attached. Cognitive development is impaired. Okay, let me fly to treatment failure. Part of the problem with treatment failure is delayed recognition and delayed start of treatment. Okay, so early intervention is very important. The rule is seizures beget seizures. One seizure will generate another seizure, especially we're talking unprovoked seizures. And the first 2 years are very critical as a window from diagnosis or from the first seizure to 2-year point is very important. And delayed treatment may create chronic epilepsy. So it's important that we respond very early to predict long-term outcomes. Even monotherapy in the first year is important. So who is at risk for poor outcomes? So there's a cohort study that was done, early life epilepsy, and the data was that mortality was 2.9% in the first year, drug resistance 35% overall, 40% of infants less than the first year, developmental decline, evolution of infantile spasms, new seizures, okay. Predictors of drug resistance is another thing. Onset less than 1 year is a predictor of drug resistance, 12% plus absolute risk. Developmental delay is another predictor of drug resistance, 21%. Both factors combined, 54%. The risking jumped. So predictors of developmental decline, maybe we'll read that on our own. And the clinical takeaway is younger age of onset is and developmental constants at the onset remains a red flag for poor prognosis. So all early life epilepsies potentially pose a risk for a troubled future. Seizures also, the case for early detection in effect and case presentation. So seizure incidence peak in the first year of life when the brain is most vulnerable, up to 87%. Okay. So the beautiful thing is the presentation is fairly detailed. You'll be given these presentations. Let me just highlight a few more things. What research tells us about the single seizure, a seizure event. By the end of 1 month from your first seizure, you have a cumulative recurrence rate of 20%. By 3 months, that cumulative recurrence rate hits 32. By 6 months, 46. By 1 year, 62. 3 to 4 years, 71%. So something to note is that a single unprovoked seizure is going to go on to develop into
Summarize, please.
epilepsy. All right, okay. So preventable morbidity, the 4 pillars for early diagnosis is motor vehicle accidents, definitely, other injuries, economic burden. We've already highlighted this thing. There's a cost implication to not treating epilepsy early. Seizure prognosis is dependent on when the diagnosis is made. 92% of monotherapy failures occur in this window, okay? And then early treatment prevents evolution to chronic epilepsy. Cognitive developmental outcomes are also a problem. And then this massive treatment gap. So what is your role? What can you do today? Screen for psychiatric comorbidities, be able to diagnose the okay, good. Let me just take away. It's very good. So our parting notes, epilepsy is a spectrum. It's bidirectional with links to psychiatry, and 30% of patients will experience depression and anxiety, and 20 to 30% have non-psychogenic epileptic seizures, non or psychogenic non-epileptic seizures, psychiatric phenomenon happen in epilepsy, and some anti-seizure medications cause side effects that are psychiatric in nature. Diagnostic delays have severe consequences, and non-motor seizures are primarily the cause of delayed diagnosis. And the first 2 years are very critical for treatment. Over to you, Dr. Kalani. We'll jog through the next few questions if there are any.
Thank you so much, Dr. Hilary Tessa, for taking us through. I I wasn't aware that there is a new classification.
Yeah.
Of, I thought I was still using the 2017 the National League Against Epilepsy classification, but this is an eye opener to me to look up. So at this point, I've taken any comments or questions. I see someone has texted that they want the presentation. I think that can be shared. I don't know if anyone has a comment or question to make based on the presentation that has been delivered. And put your hands up on the chat or type on the chat and raise your hand. And there's a question coming in from the chat. Can alcohol use disorder cause epilepsy, and what are the chances? If so, in such a case, what would the management plan look like? Probably the link
So,
between epilepsy and seizure disorder. Yes, over to you.
yes, so alcohol is an amazing substance that does cause a lot of havoc all over the body, the brain being one of those. And yes, alcohol can cause epilepsy. Usually, it is not the type that we would expect. What typically shows up in your clinic is going to be RAM fits. Somebody's either withdrawing or they have intoxicated themselves too much and then they convulse. But a few patients do actually progress to start convulsing even when there's no alcohol, when they're not withdrawing or being intoxicated. So the management would be a standard um, anti-epilepsy medication. You could choose any of the depending on the presenting symptoms of the seizure type. You could choose any of the anti-epilepsy medications available to you, and it would do the person well. Yes. It's not too common, by the way, regarding the chances. It's not too common, but it does happen. Every once in a while, I have met a patient whose epilepsy started with alcohol. They started as RAM fits, but the person quit alcohol and they continued convulsing.
Okay. Thank you. Any other question? See another question. Is there a duration for when one can be on the medication? I think still it's a follow-up question on the earlier question. Yeah. And
So
would
maybe
it
I'll
help
start
if
with
the
the end
person
of
still
oh,
continues to take
I'll
alcohol?
start
Yeah.
with the
Okay.
end with the end of the question. By and large, we would not advise you to mix alcohol with medicine. Both alcohol and most anti-seizure medications are metabolized in the liver. and they are destructive to each other, if I should put it like that. In one instance, some anti-seizure medications are affected negatively by alcohol, i.e. it reduces the concentration of the medicine in blood. Others are made toxic by increasing their concentration. So let's first deal with the basics. First, quit the alcohol. If not possible, significantly reduce the volume consumed on a daily basis. And if the person is continuing to convulse, they will need their anti-seizure medications. Those adjustments to factor in the metabolism will be needed. So they may need a bit of a higher dose depending on what anti-seizure medication you're choosing, given that the liver enzymes are super active, usually in people who take alcohol. Yes.
Thank you. We have another question in the chat. That can psychogenic non-epileptiform seizures, I want to assume that's the meaning, turn into epilepsy if someone keeps getting them often? I think, Doctor, nowadays they call them just non-epileptiform seizures, but you can tell us if I think someone's wondering if someone gets this non-epileptiform seizures, if it can turn into epilepsy.
No, it cannot turn into epilepsy unless the person already had epilepsy or they were already at risk, and for some reason or the other, something happens and they get proper seizures. But usually the psychogenic epilepsy, psychogenic seizures are psychogenic in nature, as you hear it. There is a psychological reason behind this manifestation. And usually the treatment is psychological in nature. CBT is the mainstay treatment for psychogenic seizures. And we advise you not to overdiagnose or overtreat. The correct thing I'm trying to say is overtreat or over-investigate. It is expensive on their pocket, and you know that unnecessary medications are harmful. So the presentation will give you a few things on what you need to make sure that you don't fall victim of over-investigating non-psychogenic or psychogenic seizures. Rather, if you are in a setting where there is no mental health worker, refer as soon as you are able to diagnose this, but try not to harm them. They need reassurance, and their treatment is really psychological in nature.
Thank you so much, Dr. Hilary. I think that's very clear. Last question, because we're really running out of time. I think this question is an interesting one. I don't know if we shall answer it today or in the next session. The person is asking, Benjamin is asking, if epilepsy patients should be treated by psychiatrists. He used the word "seen" or neurologists. Where should they go exactly?
I believe, Dr. Kalali, now that is yours. That one is yours. I hand it over to you.
Okay. We can answer that even in the next session, but epilepsy primarily is a neurological condition, and the neurologists are in the best place to treat. But in our setting, as Dr. Hilary presented, is that traditionally for a very long time we did not have neurologists, but also because of epilepsy being what it is, there were so many psychiatric comorbidities. You mentioned the stigma associated with epilepsy increases anxiety, depression, but also epilepsy, the common types of epilepsy that were seen were comorbid with mental illnesses because it affects the brain. So depending on the etiology of the epilepsies, many patients presented with common mental illnesses as well. So psychiatrists have taken up that role for a long time. But I think with the growing recognition of epilepsy and recognizing epilepsy of what it is and the fact that it can be treated and patients with epilepsy can receive care and remain functional, there should be shared treatment because some patients with epilepsy will have psychiatric comorbidities, but we are seeing patients with purely epilepsy conditions as well without any psychiatric comorbidities, and physicians and pediatricians should be able to manage. I think we recognize that even as a ministry, and we have we're making efforts to ensure that we improve the quality of care for patients with epilepsy. Because if you look at it, Dr. Kutesa mentioned that about 30% of patients with epilepsy may have intractable seizures. That means they have other etiologies, and there are other forms of treatment like deep brain stimulation or lobectomy, depending on the condition or the cause of the epilepsy. That should be explored. But if we continue to provide care as is, we might not provide this, we may not adequately explore all these other modes of care. So I think it's that time that we start to sit together as different disciplines, and then we harmonize to improve the quality of care and also the quality of life of patients living with epilepsy. So with that, I hope I answered it right, Dr. Hilary. This wasn't my session.
I hijacked you. Thank you so much. I do believe you have done the question justice.
Okay,
Yes.
so I want to
Mm.
hand over now. I think we've short over time. I really want to appreciate you, Dr. Hilary, for sparing some time and taking us through. As Dr. Lillian mentioned, that this is one of um, uh, two sessions. So we shall have another session after 2 weeks. This will come through as a follow-up on this session that Dr. Kutesa has just presented. I think the next session will focus mostly on treatment. And so as we've identified, we go on to treat. So I want to encourage you to join in again. Those that have spared some time to join, thank you so much. And again, we want to appreciate Microlabs for hosting us in this session. I hope learning has taken place. I hand over to Dr. Lillian to close us. Dr. Lillian?
Thank you very much, Drs. Kalani and Kutesa, for this very insightful and educative session. Unfortunately, our time is not so much, so it's very hard for someone to really talk about everything that we really need to know. However, thank you so much for educating us, Dr. Kutesa. Our next session is on Monday, next week. These sessions are going to be happening every second and third week of the month. That is Monday, every second Monday and third Monday of the month. So next Monday, 7 p.m., we shall be talking management of epilepsy and available drugs on the market. So all the people who are asking questions regarding management, please tune in next Monday. Otherwise, thank you, Microlabs. Thank you, everyone, for creating the time. Have a good evening.
Thank you. Good evening, too.
Thank you, doctors.
Mm.